Okay. Well, welcome to everyone. I can't actually see everyone, but I'm excited that you're all here today for Cover Your Colon, a federal and state perspective. We have a couple of important purposes for this webinar today. First of all, it's important to understand sort of how insurance and copays and other things work in terms of covering colon cancer screening, whether that be colonoscopy or stool tests. And it's particularly important to revisit this topic of coverage and access because the United States Preventive Services Task Force, which sets the guidelines, in addition to the American Cancer Society guidelines for when to get screened, who should get screened, and how you should get screened. The screening age had been 50 for many years, and it has now been reduced to 45 with the increased incidence of people being diagnosed at earlier ages. So we'll talk about that today. And we have three great panelists I'd like to give a brief introduction to, so that when I introduce them to give their talks, that you'll know a little bit more about their background. So Dr. Melissa Tepe from Affinia Healthcare in St. Louis. She is the Chief Medical Officer and board certified in obstetrics and gynecology, and did her residency at WashU BJC. Also has a master's in public health from Columbia University. And if you're not familiar with Affinia, it provides comprehensive health care to patients regardless of their ability to pay or insurance. So we can get a flavor for how that works when you may or may not have insurance or different types. Anna Howard from the American Cancer Society is the leader in policy development, access to, and quality of care. American Cancer Society's Cancer Action Network. And she applies her law degree to healthcare reform and more. And so we'll be interested to hear her perspective and presentation on sort of that insurance coverage and concerns and gaps as well. And then Shannon Lee Sin, also with us today. While she was getting her bachelor's and master's in architecture, she was also struggling with getting diagnosed and cared for her colon cancer. So she'll talk about sort of that personal experience that she had. And, although she was younger than most and younger than the 45 that we'll be talking about as part of the new recommendations for screening, it reminds us to be, vigilant of our own health and advocate for the care you need, regardless of what the expectations and status quo are. So we'll be excited to hear from all of our panelists. I'm been asked to remind you that you are muted, and that we will accept questions in the chat, and then we'll have time at the end for questions and answers, and we certainly want your involvement. There's also a pre-test. There will be a quiz right now. We'll ask some questions at the beginning, and you should be able to see those on your screen. If you wouldn't mind answering those, give us a sense of what people have to say at the beginning, and then we'll have a post-test at the end. And I think that's it. I can start with the first transition for Dr. Tepe's presentation, and she can share her slides.
We're good to go? Everyone can see the slides and hear me? Well, good morning, everyone. I really appreciate being able to share kind of my experience at Affinia Healthcare, which is a large community health center in St. Louis, with all of you today. I'll also share a tiny little personal story as well. So as mentioned, Affinia Healthcare is a community health center or federally qualified health center. We have multiple locations in St. Louis. We do primary medical, behavioral health, and dental care. And we do see patients regardless of their ability to pay. So as a community health center, we're not a free clinic. There is a sliding fee if folks are uninsured, but that is to be based on family income. And ours starts at $20 to $25. And then we do accept Medicaid as well as private insurance. So I'm going to focus on the colon cancer screening kind of issues for the under or uninsured patients that we see frequently. So these are just some of the options, probably the more common ones, the options for colon cancer screening. So I misspelled colonoscopy there, but it is still a full test, even if you miss the last O. So that is a test by which, right, it's a procedure. You are going to be made very sleepy. It's usually either in a procedure center or in a hospital, and the entire colon is looked at, right? It can also be therapeutic, meaning that polyps can be taken out, right? Tissue can be biopsied. And so this is the gold standard of testing. If it's completely normal, you can hopefully wait 10 years. Again, all of these start at age 45 now for the general kind of average risk person. So colonoscopy there is our gold standard. One issue with the colonoscopy, right, is that you need a ride. You need someone to take you. You're going to have anesthesia, so you really shouldn't drive afterwards. You do have to do that lovely prep beforehand, right, to clean out the colon so they can get good pictures. And if you are uninsured, right, this could cost up to $5,000. Then we also have the stool-based kits. So Cologuard is a bit newer, stool DNA testing. If this is negative, this is good for 3 years. And generally speaking, this is more expensive. This is generally now covered by insurance, and in Missouri, it is covered by Medicaid, which is good news. That's a fairly recent development. And then we also have another stool test, which is the FIT test, also can be done at home. If this is negative, this needs to be done every year. The stool-based kits of Cologuard and FIT can be done at the comfort of your home, can be mailed or brought back into the office. If they are positive, what do they need? A colonoscopy, right? So for folks who are under or uninsured and worried about finances or just ways to get to the colonoscopy, if you're positive, then you still have to think about that next step, and that can be scary. There's also like a sigmoidoscopy, which is a scope, but of the lower part of your colon, or like video CAT CTs. We just don't use them clinically very often in my practice, so I'm going to kind of skip over those. I just wanted to say thank you. Like, in order to do the work at Affinia that we do, we have wonderful partners, PCAD at WashU, the American Cancer Society, and WashU, the Division of Gastroenterology, really to work through these processes so that we have systems in place for people who don't maybe have all of the resources we would all want to get general screening done. We have also added community health workers for this type of work, screening our general population, and you'll see shortly for some special populations as well. So we see a lot of, most of our patients are historically marginalized in one way or another, right? They have had systems and barriers put up so that they cannot readily access healthcare, education, transportation, good paying jobs, housing, all kinds of things, you name it. We have put up barriers as society for them to be able to do those things. So continually breaking down those barriers and also continually then regaining trust, right? It is scary to talk about cancer screening. It is scary to get some of these tests done. And you really need to be able to trust the healthcare system and the clinician and the healthcare teams that you're talking to. So we have added a community health worker to have more of those in-depth conversations, to ask what those barriers are and to pull them down with the patients so that we can get some of this accomplished. We also see a large number of refugee and new immigrants to St. Louis. So we have additional language barriers here. We also have cultural considerations here, right? If you are new to this country, the American healthcare system is super complex. And also the idea of screening, the idea of having a testing your stool or going in for a procedure when you don't feel bad is not the usual for many folks. So when we have metrics, right, in the system that like everyone over 45 should get their colon cancer screening, I totally agree, but that might not be the first thing that we are able to accomplish with a new refugee, right? It is just something that needs lots of conversation. So for this group as well, we have community health workers and navigators to again just reinforce some of those educational, right, and concerns, those barriers. Again, here's just a list, and this is not an all-inclusive list. I am sure all of you have other ideas on what to put up here, but right, things you really have to think about when you're getting your colon cancer screening. Fear, right? Fear if the screening test is positive and you need the colonoscopy, fear of having cancer, fear of not being able to get things done, the cost and the paperwork. Um, you need some labs that are current if you're going to get a colonoscopy for many places, right? Can you come in and get that? Transportation, support person. This is also not something you can ride a bus home from, right? If you're getting a colonoscopy, you need a support person there. Childcare, time off work, the prep medications, the procedure and the anesthesia. And then often even if you're comfortable maybe in the community health center or in your local office, this is a new facility that you're going to that maybe you're not comfortable with. Maybe you don't trust those folks. And so again, not an all-inclusive list, but some things for consideration. And at Affinia, I would say are for the uninsured, and we're going to get to some patient stories here in a second. We've done a lot of work. Our uninsured patients typically get a FIT test first. So that's the 1-year stool-based test, because we can do that for free. But then lots of education, right? Because if that's positive, we're going to need to find a way to get you that colonoscopy, right? So I can remember before we set up systems in place with WashU and with grants through the American Cancer Society. So now if you have that positive FIT test, you still have to complete all of the paperwork, which is multiple pages, for charity care at Barnes and at WashU. That's 2 separate processes and forms. But through a grant, then, if you're uninsured, we can get you your free colonoscopy at Barnes WashU through a grant. So again, lots of paperwork, but in establishing that process and just getting better on our documentation, doing more FIT tests then, adding the Cologuards several years ago, you can see that our percentage of colon cancer screening has gone up drastically in the last 10 years. And we really were trying to hit that 40% mark, and we're there, and we're going to try to maintain that and go up even more. So to highlight some of the barriers or considerations, I want to share a couple of patient stories from our wonderful community health worker that really focuses on colon cancer screening in patients. So one is a 50-year-old female patient who identifies as Black, and she does have insurance. She decided, though, she would like to do the FIT kit at Affinia because there were other considerations. Housing wasn't quite stable. She didn't have a lot of family support to be able to get to a colonoscopy, and transportation was an issue. So she did the FIT test, and then it was positive. Right? So now what? Those same barriers that she had for not choosing that colonoscopy in the first place are still there. So again, this community health worker being able to take the time to break down those barriers, finally able to get this patient her colonoscopy several months later. Our community health worker went with her. She was her support person, and they used Uber Health to transport to and from. So breaking down some of those barriers for that patient. Next patient, 64-year-old female who identifies as a Latina. She does not have insurance. So her really best option due to cost was that FIT test. It was also positive. Her biggest barrier to getting that colonoscopy was fear. She stopped answering calls, did not return letters, was really afraid that she had cancer, and really immobilized her, did not want to hear from us. So the community health worker did several home visits. And after those several home visits, they worked through some of that fear, and the patient was able to go with her partner, completed all the paperwork for Barnes and WashU for that charity so that she could go through the grant. got her colonoscopy, had a couple of polyps, no cancer. It took 1.5 years for that process to complete itself, right? For that patient to be able to get from that positive FIT test to the colonoscopy. So again, the importance of that follow-up. One patient accepted the FIT test, again, uninsured, because she said, yeah, if it's free, give me that FIT test, I'll do it. But then again, positive, right? So again, that follow-up on the colonoscopy, worked with the community health workers to get past some fear, and she got her colonoscopy about 4 months later. And finally, from the patients, we had one male patient who got uninsured, got his FIT test, then that was positive. He was afraid of the kind of charity care paperwork process. Even though we tried to reinsure that that grant would cover the cost of his colonoscopy, he had had procedures a couple years before through charity care in which the bill, he received some financial assistance, but still received several $1,000s worth of a bill from the prior procedure. So just super scared of that financial burden. So they ended up actually going to a more private facility in which they quoted him like $1,500 to get the colonoscopy, and he did get it completed in that way. But his barrier again was the fear of the unknown, of that financial burden. So just some examples of how getting through this process can be difficult, right? For anyone, even with resources. So that other picture there of the gentleman in the mask, that is my husband. And then I am there next to him. And so my story is a little easier at the age of 45, right? The recommendations had changed and I went ahead and got my colonoscopy. I was a little disappointed. I had 3 polyps and I have to go back in 3 years. I would really wanted that 10-year window from colonoscopy to colonoscopy, but just didn't happen for me. But I am happy to know, and I will definitely go back after my 3 years. And finally, there is my husband, who the recommendations changed kind of right when he went from 45 to 46. And I said something, but does he believe his OBGYN wife, who is, of course, has knowledge on colon cancer screening guidelines? No. So I asked him to ask his endocrinologist, who says, yes, your wife is correct. The age is now 45 and you should get a colonoscopy. So I went with him to his colonoscopy. This gentleman right here, who I love very, very much, had a large 4.5 centimeter precancerous, huge polyp in his cecum. So far, far over in that right colon. Only way you're going to see that thing is a colonoscopy. That gentleman then a month later had a laparoscopic left colectomy, took out his whole left colon, but no cancer. I am very thankful of that. They took a few lymph nodes, nothing there. So he is at yearly screenings for colon cancer now via a colonoscopy of the remaining colon that he has. But again, if he had waited longer, right? If he had not had someone pushing or put this as a priority, I'm pretty certain in a few years, we would have been going down a different treatment path, right? Likely surgery, chemotherapy, and who knows what we would have been doing. So again, very, very important to get these cancer screenings. And I can tell you personally, I'm very thankful for them, even if they seem annoying at the time. And with that, I will say thank you and hand it back over. I'll stop sharing and mute myself.
Okay. And then we can transition Anna Howard from American Cancer Society Cancer Action Network.
Again, awesome,
Yep,
great.
Go ahead and put it into
So
mode.
I am Anna Howard. I am a policy principal at the American Cancer Society Cancer Action Network. We are the advocacy arm of the American Cancer Society. Let me just put this in presenter mode. Are you still seeing, do you see notes or just slides?
Yeah, we can see your notes.
Okay, let me just
I think if you
go
click
back
that,
one.
Yep, it was that button.
the one at
back
the
up.
top.
There
Yeah.
you go.
Okay.
Yep, click it.
Awesome,
Yep, there you
great, even better. Apologies for the technical difficulties. So, you know, as Dr. Tepe noted, We at the American Cancer Society are committed to ensuring that everybody who should be screened for colorectal cancer is screened for colorectal cancer. Colorectal cancer is the second most common cause of cancer death for both men and women in the US. We are seeing an increase in the incidence for younger individuals, which is why the recommended screening age has been lowered to 45. And as Dr. Tepe just so artfully said with the personal story with her husband, early diagnosis really increases the survival rate for colorectal cancer screening. Polyps, through screening, polyps can be found and removed, which is why it's so important to get screened. But unfortunately, only 1 in 3 cases are diagnosed at the local stage, which is why we need to do whatever we can to increase screening rates. And at American Cancer Society, Cancer Action Network, we are fighting to make sure that everybody who should be screened has both not only access to colorectal cancer screenings, but gets the colorectal cancer screenings at no cost, and that we remove as many barriers as possible to the screening. And it's our position that everything up to the point of diagnosis should be considered screening and thus should be available at no cost. So these are the tests that the United States Preventive Services Task Force, that's a mouthful, recommend for colorectal cancer screening. So if you're not familiar, the U.S. Preventive Services Task Force is an independent, evidence-based entity that recommends preventive services for individuals of average risk. And this is their most recent, from May 2021, recommendations for colorectal cancer screening. You will see a lot of different options that are available and recommended, and the different options come with it, how often one should go about getting the screening recommendation. So you'll see colonoscopy is recommended every 10 years, whereas a stool-based DNA test recommended every 1 to 3 years. The U.S. Preventive Services Task Force recommends that individuals start cancer screening at 45, and that screening goes up to age 75. The task force also recommends that if you take one of these stool-based tests, that's the line in blue at the top, and those tests come back positive, then a colonoscopy should be followed in order for you to complete the screening. And that's important because, again, we want to make sure that screenings are completed so that if polyps are found, they can be removed in a timely manner. Unfortunately, nothing in the world of insurance is necessarily easy, so I'm going to spend the rest of my time talking about insurance coverage. I promise that I'm going to try to do it in a way that will not make your eyes glaze over. But depending on how an individual gets their insurance coverage, from where, that's going to depend on what tests that you get, and whether or not you have any cost sharing, whether or not you have to pay for any of the tests. So I'll start with the Medicare program. The Medicare program is a federal program primarily for individuals age 65 and over, but does cover some individuals who qualify based on disability coverage. Their coverage in terms of what that they cover is similar to what the United States Preventive Services Task Force recommends, but Medicare is a federal program. They're going to do things their own way. They have kind of a different process for determining coverage. So it's similar to what the task force recommends in terms of it covers most of the colorectal cancer screening tests without cost sharing. They recently lowered their screening to begin at the age of 45. They cover follow-on screening, colonoscopies. That is, if you go for like a FIT test or a stool-based DNA test, a Cologuard test, and that comes back positive, Medicare will cover the screening colonoscopy at no cost sharing. But they also have some different coverage rules as well. So if you have Medicare and you go in for what you think and what your doctor thinks is going to be a routine screening colonoscopy, and during the course of that screening colonoscopy, a polyp is found and removed, then you will have cost sharing. You will get a bill from your provider, and you're like, why did I get this bill? Is a screening colonoscopy? It's because of Medicare rules that change the screening colonoscopy from a screening colonoscopy to a diagnostic colonoscopy. The good news is that this is being phased out. And so over time, the amount of what you're going to have to pay is going to be reduced and ultimately eliminated, thanks to efforts from ACS CAN and gastroenterologists and society and others. Medicare Advantage, which are the private plans that provide Medicare coverage. About half of Medicare beneficiaries choose to enroll in Medicare Advantage plans. These plans have to cover the same rules as what is covered under Medicare. The only difference is they have some flexibility. So depending on the plan, they can entirely waive cost sharing. So if a polyp is found and removed during a screening colonoscopy, you may or may not have any cost sharing associated with that. That's entirely up to your Medicare Advantage plan. So Medicaid is a joint federal state insurance program for individuals of low income. There are, under the Medicaid program, you've kind of two different populations of people. Again, insurance, never easy. So you have what is called the traditional Medicaid population. For this population, the colorectal cancer screening is an optional benefit category. So that's really going to depend on your state. Most states choose to provide some coverage, but that's really going to depending on, what state you're in and what your state decides to do, because that's entirely a state decision. Under the Affordable Care Act, individuals up to 138% of the federal poverty level can qualify for Medicaid if their state has chosen to expand their Medicaid program. 40 states and the District of Columbia have so far chosen to expand their program. These individuals will get coverage according to the U.S. Preventive Services Task Force recommendations that I showed earlier, and will not have any cost sharing. And then in the commercial market's kind of a wonky term. If you get your coverage through an employer, or you're a spouse of an employer, or you buy your coverage on the individual market, you go for one of the marketplace plans, or you buy individual coverage. If your plan is compliant with the Affordable Care Act, and you'll know this because you'll get a summary of benefits and coverage when you sign up for the plan, and it's 8-page front and back document that has all sorts of information about your plan. These plans have to cover the recommendations that I showed earlier without cost sharing. And also, if a polyp is found and removed during the screening colonoscopy, you won't face any cost sharing. Some people have what are called grandfathered health plans. These are health plans that were in existence as of March 23rd, 2010. That date is important because that's the date that the Affordable Care Act was enacted. And under the Affordable Care Act, plans could choose, if they weren't going to make any changes to their plan, they could choose to have kind of what's called grandfathered status. These plans are not required to cover colorectal cancer screenings, but many choose to cover. So how do you know if your plan that is offered from your employer is an ACA plan or a grandfathered health plan? You have to call your employer and find out and ask. And then in addition, a couple other things that I'll mention is state laws. So some states have what are called coverage mandates. Many of these were like in existence prior to the enactment of the Affordable Care Act. And they require health plans in their state to cover colorectal cancer screenings. There's going to be a lot of variation on these state mandates. So some states will say, hey, health plans in this state have to cover colorectal cancer screening in line with the American Cancer Society, for example, recommendations. Or they'll say, health plans in this state have to cover, these two, colorectal cancer screening tests. It's going to really vary a lot depending on where you live. And some of these, again, some of these state mandates were enacted prior to the ACA. And so, in some states, we're pushing to make sure that there is coverage of follow-on testing. So far, we have been successful in about 15 states to make sure that there is coverage of follow-on testing. So if you have like a stool-based test and you need a colon, that comes back positive and you need a colonoscopy, we want to make sure that that's covered without any additional cost sharing. So it would be free and covered. There is a requirement under the ACA that states do have to, pay their insurers if they pass new state mandates. That is going to depend a lot on individual states. So just wanted to kind of throw that out there for you. And with that, here is my contact information if you have any questions. Thank you.
Thank you. And then our last speaker, Shannon, we're happy to hear your personal experience.
Hello, everyone. Thanks for tuning in. I am Shannon Leeson. I am currently 42 years old. I was born in Jamaica, and I am of Asian, European, and African descent. I am now a 12-year colorectal cancer survivor and an advocate full-time. I've had strange pains in my abdomen since at least when I was in high school. When I think about it, I kept asking and complaining about the pains I woke up with every morning, the same pains that sometimes I'd go to bed crying from at night, and that would wake me up out of my sleep like a nightmare. I asked my pediatrician about the chronic abdominal pain and the blood in my stool, and I was diagnosed with a stomach ulcer at 17. However, I didn't ever have an endoscopy or a colonoscopy or any other type of screening test done, not even a scan. I was told to take antacids, which never helped. So how sure can I be that it was in fact an ulcer in my stomach when I was a teenager and not some monster growing within me, killing me slowly from the inside over the next 12 years? At 18, I went away to college in New York. I remember seeing blood in my stool a few times once again. I brushed it off. I'm not really sure why. I was taught in my high school biology class. I did both honors and AP. My mom's a biology and anatomy teacher, and I've just always loved the life sciences. I was taught in high school biology that blood in the stool could be a sign of something serious, such as colon cancer. However, I was told, just like everyone else at that time, that colon cancer was typical in people over 50, especially men. In my mind, I was way too young for colon cancer, and that is probably why I brushed it off. After all, I was also taught that it could be one of the symptoms of stomach ulcers. I now know colon cancer doesn't just sit around waiting for you to be 50 years old before showing up and trying to kill you. And I learned that the hard way. Fast forward a little over 10 years, I was attempting my bachelor's degree again. I was an architecture student, yet again, but this time in Jamaica. During my first semester, I had diarrhea for a few days. I went to the doctor and I was diagnosed with gastroenteritis. I had diarrhea for 2 more weeks after that, despite medication. I thought the diarrhea and the stomach cramps I was experiencing weren't normal, but I figured I wasn't a doctor, so what did I know? The diarrhea eventually subsided, but the cramps, bloating, and discomfort would return occasionally. With time, it all became more and more frequent. However, I chalked it up to having an ulcer again, especially since my doctor didn't think anything was wrong more than that. Then it was in my 3rd year of school that I saw blood in my stool once again. The water in the toilet bowl was red, as if someone poured a liter of red food coloring in it. I panicked and I went to the doctor the next day. I was told I had hemorrhoids, probably due to the stress of school, and they need to drink more water and eat more fiber. And I'm still being told that now, even as a survivor, when I go to the emergency room. The doctor didn't even examine me physically or do any tests once again. A few months later, I began experiencing chronic nausea, vomiting, fatigue, abdominal discomfort, and bloating. I somehow also managed to have alternating constipation and diarrhea. The symptoms would subside for a month or two and then return with a vengeance for a week or two. I went to a doctor each time, but most of them didn't find anything wrong. And they referred me to a gynecologist, although all my symptoms were GI and gastrointestinal and digestive. However, after a year of suffering, my gynecologist performed an ultrasound and diagnosed me with ovarian cysts. The doctors felt it satisfactorily explained my symptoms. The following year, I was admitted into the hospital for being severely anemic, and while hospitalized, I ran a fever of 103 degrees. I was told I was anemic due to having heavy periods and that the fever was probably just a symptom of a bug I picked up while in the hospital. The doctors wanted to give me a blood transfusion, which I feel should be a life-saving measure. And yes, I was severely anemic, but due to the risk, I asked what was my diagnosis so I could make an educated decision. I was told it was my heavy periods, and I did not feel that my symptoms and the anemia lined up with that, and it just didn't make sense. So I decided to keep advocating for myself because I felt that if I did a blood transfusion, I would have kept on being anemic and the problem never would have been solved, and I wouldn't have gotten a real diagnosis. I just felt in my gut that something was really wrong and they were way off. I asked the doctors if my anemia and fever could not be from heavy periods, but could possibly be the sign of an infection somewhere. I was brushed off. I was discharged from the hospital because I refused the blood transfusion, since I didn't feel it satisfied me for an explanation for my anemia, fever, and all the other symptoms that I had been experiencing over the years. Over the next few weeks, the pain, vomiting, and diarrhea were so bad that I had to go into the emergency room at least 2 to 3 times a week to get some sort of relief from the excruciating pain, and I would still go to school the next morning. My family thought it was all in my head, and I was just seeking attention. The lack of medical diagnosis had me thinking I was going crazy and I wasn't really sick. Unbelievably, despite over 2 years of constant suffering, I managed to finish my bachelor's degree. In June of 2011, I traveled from Jamaica to Miami at the guidance of my mom, who urged me to come up and get another opinion after seeing over 20 doctors in Jamaica. So I came up here to see if someone could figure out what was wrong with me. Within a week, I ended up in the emergency room and I was told I had cysts yet again after having an ultrasound done. 2 days later, my mom came home from work to find me crying in bed from severe pain, with my abdomen bloated and my skin turning an orange hue. She immediately took me to the emergency room again, where I underwent my first CT scan, and my blood was drawn. The CT scan showed that I had an enormous abscess in my abdomen, and the blood test revealed that I was septic. I had to have an emergency blood transfusion and had to stay in the hospital for 2 weeks, as well as a stay in the ICU for about a week. The doctors decided the safest option for me and the best way to avoid me having an ostomy was to treat the infection and then wait for the inflammation to resolve so I could do a colonoscopy, which was far less invasive and risky than undergoing surgery. I ended up being admitted to the hospital twice more between June and September with the same infection. I had E. coli and 5 other bacteria in my bloodstream. It was at that point that my medical team decided that I should undergo exploratory surgery. I asked if it could be cancer. However, I was told I only had a 5% chance of having cancer and that due to my age, it was more likely diverticulitis, irritable bowel syndrome, Crohn's, ulcerative colitis, or perhaps some kind of infectious disease. I want you to note that in 2011, I was told I had a 5% chance of having colon cancer being under the age of 50. That statistic in my 12 years of diagnosis has quadrupled. It's now 20% chance of being diagnosed under the age of 50 if you have a colon cancer diagnosis. That statistic is staggering. And by 2030, this will be the #1 cancer killer of people like me. In October of 2011, I went into what should have been a simple 45-minute long surgery to come out 10 hours later and being told that not only did I have stage 3 colon cancer at 29 years old, but I also had an ostomy. The few days after I was discharged from the hospital were a whirlwind. I went to my first oncology visit the following day after being discharged, and then flew to Jamaica for my graduation the day after that because I'm just crazy. I returned to Miami 3 days after and underwent my first chemo of 12 rounds, which took 6 months. Each chemo was 3 days long, about 72 hours, continuous even while I was sleeping. And trust me, it drained everything out of me. During this time, my grandfather was diagnosed with pancreatic cancer a month after my diagnosis, and he passed away in January in just 6 weeks. Watching my grandfather, my best friend, fight cancer while I was, and then succumb to it was the hardest thing I've ever been through in my life. And it made me see that in some ways, watching a loved one fight cancer can be harder than having cancer yourself. And it also reminded me of how real my mortality was. I had my ostomy reversal surgery in January 2013 after having an ostomy for 15 months. 2 days after being discharged from the hospital, I went to the FIU, Florida International University, and I applied for their Master of Architecture program. I decided cancer didn't kill me and it wouldn't kill my dreams either. I began my degree program that summer, although having a scare and then thinking that I had cancer in my liver, which would have made me stage 4. I still went to the UK to work for an architecture firm for 2 months. I also started my master's degree not knowing whether I had stage 4 cancer. I graduated with my Master of Architecture degree in June of 2016. I've been working in my industry until recently. I did not find out until 2018 that what was seen on my liver was actually NASH and was fatty liver damage caused by the chemo and not actually cancer. So I ended up being very lucky, although having that scare. I recently left my career, so that brings me to where I am now after diagnosis and surviving for 12 years. I recently left my career as a construction manager due to quality of life issues from the long-term side effects of cancer treatments and surgeries. I have now become a full-time advocate against this preventable disease. I have started Blue Couch Chat, a live stream channel on all social media channels, as well as YouTube. I've also founded the Blue Couch Chat Foundation and the Architects of Hope International. My main goal is to raise screening rates and reduce mortality in the high-risk and vulnerable communities with a focus on young onset colorectal cancer. Life after cancer isn't easy. I still have long-term side effects from chemo and multiple surgeries. Looking back at my story, I realized several things. Firstly, it is important to not only be your own advocate or to advocate for others, but to also teach others how to be an advocate for themselves, as well as for others in turn. Advocacy, especially self-advocacy, saves lives. It saved mine. It is important to teach others the symptoms of colorectal cancer, but also that colorectal cancer doesn't discriminate based on age, race, or gender. It is not an old man's disease. If I didn't keep pushing for answers and asking the doctors questions, I would be dead. If doctors don't listen, keep pushing until you find one who does and who will advocate for you and fight for you as hard as you are fighting for yourself. It has taken me 12 years to get a team of doctors together who I can trust my life with after all that I've been through. And it is the most important thing for survivorship. Secondly, having cancer doesn't mean that you have to stop living or that you can't lead a somewhat normal life. Yes, cancer changes you forever, emotionally, physically, and mentally. However, despite having cancer, I've still been able to not only complete 2 degrees, I've been able to pursue and achieve a successful career, and I've also been able to enjoy my life and do things that I thought I would never do, such as surfing and paddleboarding, which were completely out of my comfort zone, but have changed my life and taught me that I'm to live with loose knees and just balance on my board and ride the waves of life, including cancer. It may sound contrite, but it really is true. You may have cancer, but cancer does not have you. This is a preventable disease. My cancer did not show on a scan. So please do your colonoscopy. It's still the gold standard for a reason. It's the only way to not only screen and diagnose, but to actually prevent this disease. If you undergo a different screening option like the ones that were mentioned before, and you do test positive, please follow up with a doctor and insist on a colonoscopy. I do a colonoscopy every year since my diagnosis. I've lost count. I'm now 12, 13, 14. I don't even know. So that tells you it's not that bad because I lost count, but I can remember that I did 12 chemos and how many surgeries. Don't be scared of the prep. I did my last prep on a plane and I was not in the bathroom the entire flight. I only used the bathroom once and then I did the rest at home and it wasn't that bad. The preps are a lot easier because they've realized that the prep is a huge barrier to people being scared of the scope. And so they've improved the prep and they're continuously coming out with new ones where you drink way less fluid and it's not as bad with the cramping and the diarrhea and whatever you're scared of. So discuss that with your doctor and they can find an option that will work for you and be less scary for you. So don't let that be a barrier. I do have to do a colonoscopy every year because I always have multiple polyps. And when I say multiple, I mean 9, 12, 15. That 1-foot resection that they took out during my surgery originally had between 15 and 20 polyps in 1 foot, and I was only 29. So there's probably something in my body, although I tested negative for all kinds of genetic mutations so far. And that is why I do a colonoscopy, because at 12 years, I have a low risk of recurrence in my original cancer coming back, but I have a high risk of developing colon cancer again as a new primary. So doing a colonoscopy every year is my way of keeping myself alive and making sure that this preventable disease doesn't come back. So if I could do prep on a plane and a colonoscopy every year, what is your excuse? Think about what's keeping you from doing the colonoscopy and either reach out to me or talk to your doctors about it. People think a colonoscopy is annoying, but you know it's really annoying and never stops affecting your life in a negative way? Colon cancer. So please do your colonoscopy if you have any symptoms, such as a change in bowel habits or any of the ones that I experienced. Sometimes you have no symptoms and you could be stage 4. So please do that colonoscopy. If you have a family history, and especially if you're 45 or older, this is the #1 cancer killer of men under 50 and the #2 for women under 50 in this country. Being of African descent, we are at an increased risk on top of that. The truth is, you are never too young for colorectal cancer. Kids and teenagers are dying from this disease every day, and I have seen it personally, and it's heartbreaking. So please get screened. If you have young children, check their stool. Ask them how they're feeling. If they have a stomach ache, don't think that it's just because they don't want to go to school because they have a test or they're being bullied. Really investigate. If they keep having a stomach ache or anything that just doesn't feel well, take them to a doctor, and you have to be their advocate. That's why children are vulnerable, because like me, I had to depend on my parents to advocate for me at 17, and I didn't know how to do it for myself, although I figured out how. If you have a hard time getting to a colonoscopy or you're scared of it, imagine finding a way to get through chemo every other week for 6 months, surgeries, and follow-up care for the rest of your life. Please do your colonoscopy. It is literally life-saving. If you have any questions or need help or support, please feel free to reach out to me. That's why I'm here. That's why I do what I do. You can reach me at Blue Couch Chat on YouTube and on all social media, or via email at bluecouchchat@outlook.com. I'm always here. No one should go through this alone like I did.
Done. Thank you so much. I know others had put in the chat too, you know, having a personal story is always brings it home, right? It tells us why we're here, what we want to accomplish. And certainly the healthcare centers, PHINIA, and then the American Cancer Society do a lot of the work for us. So we're just happy to help disseminate this information, answer questions, and hopefully increase cancer screening rates. I forgot to introduce myself at the beginning. I was so excited to introduce all our speakers. I'm Amy McQueen. I'm a professor at the School of Medicine at Washington University and a member of our longstanding university community partnership to address colon cancer prevention and control. So we're happy to host these kind of events and go out to the community just to promote, you know, the guidelines and the ease of access to these tests. It's not always easy, especially without insurance, but we can make it happen. So there are some questions in the chat. Please continue to put them there. And then, you know, I can start helping field them to our speakers. One of the questions was about, you know, the community health workers at PHINIA certainly do the lion's share of outreaching to patients, following up, making sure they can follow up with the tests they need. Are there suggestions for what clinics can do if they don't have community health workers, or also maybe how the community can help support others who are going through this process? I don't know if Dr. Tippy, you want to start?
Sure. Yes, I realize not everyone is able to have a community health worker. I do think at the very least, we often on the medical side, we'll have different systems in place, right, for follow-up of different lab results. So at the very least, between the clinicians and the nursing staff, have a process for what happens if there is a positive FIT or Cologuard. You know, even if it's not a community health worker that's able to make a home visit or take Uber Health with a patient, at least phone outreaches, at least letters. And I know maybe that doesn't feel perfect, but just because it's not perfect doesn't mean we shouldn't do what we can, right?
Mhm.
So to continue those outreaches, don't quote unquote kind of give up, right? The patients need to know, even if they may not be receptive, I think in that moment, that we feel they're important. We feel this issue and the follow-up is important. And you never know when that switch may change in their head, right? In which they may call back in and say, okay, now I'm ready for that colonoscopy, right? Or even if they come in a year later for their physical, remind them again, kindly don't give up, right?
Mhm.
Even if it's a process between clinician and nursing to patient, that's okay.
Makes sense. And then Anna, I don't know if you have any comments on that question, but then also there was a question for you about, you mentioned Medicaid, or sorry, Medicare cost sharing might be phased out in terms
Yeah.
of the follow-up colonoscopy. And someone was asking like when that might be, or if you know.
No, a great question. So under Medicare, if you have traditional Medicare, you were charged 20% of the cost of the colonoscopy if a polyp was found and removed. That could range, but could be like, $400, which again, for older Americans who are more likely to be living on a fixed income, that can be a barrier. And so under legislation that passed in 2020, that cost sharing, that amount that you're going to be paying, is phased out over time and will be eliminated by the year 2030, which sounds like it's far away. But you know, things move slowly in the insurance world. And Congress wanted to make sure that they, you know, kind of slowly phase this out over time. Again, I just want to reiterate, and, you know, I think that Dr. Tepe and Shannon, you know, both with their personal stories, and wealth of information, if you walk away with nothing else, make sure that you are getting screened for colorectal cancer screening. There are a lot of barriers. There's a lot of help out there to help people kind of overcome the barriers. You know, colonoscopy, you know, may be the gold standard, but the right test is the test that gets done. And, you know, there is coverage for follow-up colonoscopy. So if, you know, your health plan covers it, you want to do a test in your home. And then if you need to get the colonoscopy, you know, done if that test comes back positive, but we do need to make sure that people are getting screened for colorectal cancer.
Definitely. So Shannon, there's a couple of questions for you. One is, you know, tips on navigating and advocating when you are experiencing symptoms. And of course, any GI symptoms are sort of vague and, you know, can be overlapping, right, across conditions. But what other tips might you have for people who need to advocate and find the right solution for themselves?
To be honest, when I was diagnosed, I didn't have any insurance. And so my barrier, what made me wait when I came up here, was trying to get into the public health system and get into the Community Health Institute clinic, which would have given me free screening and treatment, but they didn't have any openings for about 8 months because they're overwhelmed. So that system didn't work for me. And it got to the point where there was literally one day, that's how I ended up at the emergency room. I was scared of medical bills like everyone else, right? I wasn't working yet. I hadn't started my career yet. I just graduated. And so I literally felt like the life was leaving my body that day. And I said to my mom, Mom, I have to go to the emergency room because I'm either going to have medical bills or you're going to be paying for my funeral. That's how sick I felt at that point when I came up here, and I was only here for a week. And so it became a point of realizing that my life, there is no money, no medical bills that's worth me not being here. And so don't let money or medical bills keep you from getting screened. When I was diagnosed, I ended up qualifying for Medicare and for Medicaid, and I had no bills to pay for treatment or anything else. God will work things out for you. The universe will work things out for you. You will work things out for you. You will find a way to make it work. But there's no point in not living and dying from a preventable disease just because of barriers and being afraid of financial stuff. Because you want to know the truth? Having colon cancer is way more financially toxic and devastating than anything else. So just get the screening because it can't be worse than what you're going to have to pay for the rest of your life financially for colon cancer. I'm still struggling to pay my medical bills just to keep up with my follow-up care. So I just want to say that. And then, you know, having a job, it's hard because even with just co-pays, there was a month where I was working and I had my employer provided insurance, which was great. I was working for local government. I had the best type of insurance anybody could have. And yet I spent about $2,000, $3,000 just in copays and medications in 1 month while working and still paying a really high premium for good coverage. So just do the colonoscopy. It's way cheaper than anything that you would have to go through if you're diagnosed. So you're actually preventing yourself from financial toxicity and trying to get screened and prevent being sick. It's more expensive to cure yourself or treat yourself than to actually prevent this. I want you to understand that.
That's a good point. And it, the next, one of the other questions that pop up is, you know, if someone's not really the type to go to the doctor, right? And you're trying to advocate for your siblings, your family members, you know, are there workarounds? And Dr. Tepe, you might know, like, if you have a doctor, you might be able to get them to order Cologuard for you without even coming in for a physical exam, if that's a barrier for you.
Establish patients somewhere. right? It's more likely that, yes, they would be willing to, if you meet the
Mhm.
age requirements, right, order the test and that can be sent to your home. Um, or ask for telehealth, right?
Yeah,
Like maybe you're
yeah.
willing to do a phone or a video visit. It's going to be a little harder if you don't have any established, I think, primary care relationship. But again, sometimes you need to advocate for yourself or your family member. Maybe even that new patient visit can be telehealth, right? As you're building trust, that's probably not going to be the office's preference, right? Because
Mhm.
other things we want to happen at that first preventative visit. Um, but in establishing even a telehealth visit, maybe that helps you trust who's ever on the phone or video with you, that maybe next time you'll go into the office for the other things. So,
Mhm.
you know, as Shannon would say, also, it's not always about perfect, right? And never stop advocating for yourself and your family member either. Like try to find that workaround or that shared um
Mhm.
that shared goal.
Yeah, others on the call might also be able to tell we have community events where we pass out fit kits and have a process to like follow up about the results. And, if someone ends up needing a colonoscopy, then we work through that process as well. So there is ways, yeah, to still seek screening, even if, there are barriers to seeing a provider. Shannon, you had an idea though.
I do. When you want to advocate for somebody who doesn't want to advocate for themselves, my mom was my primary caregiver, and she, as we know, caregivers tend to focus on their loved one more than themselves, and especially a mother of a young, daughter who's going through this, having to do it all by herself. My mom was 65. Now, I had colon cancer at 29, which means that my siblings, my little brother, has to do a colonoscopy starting at 19, which meant that everyone, except for my little brother, was way over the age to get a colonoscopy because of their new family history, right? Everyone went and did a colonoscopy when I was diagnosed. I am Chinese Jamaican. My dad's family, they're not going to do a colonoscopy. Jamaicans, they're not going to do a colonoscopy. They're not going to go to the doctor. They're going to drink some tea. They're going to do some herbs like what I was doing, right? So everyone went with my urging. I said, y'all are overdue now. Everyone go. So my dad went at 60, got his colonoscopy. My mom still didn't. So what I did was I had my colonoscopy that year, and everybody who's done a colonoscopy knows what we all look forward to. The best part is when you're being put under the anesthesia and counting back from 10 and feeling like you're going on a nice nap, like a wave. And during that time, I'm fighting it and I'm saying, doctor, I'm not going to put his name out there, but he's a wonderful GI. And I said, doctor, can you do something for me? And he's like, what? And I'm like fighting it. And I'm like, can you please talk to my mom? She hasn't had a colonoscopy yet and she's in her 60s. And he's like, I'm on it. Had my mom come with me to my follow-up. Now I had done how many colonoscopies in that year? Like at least 6, 7 colonoscopies she's seen me go through. She saw me go through chemo and surgery, still didn't do hers. I had her come to my follow-up appointment with me, and my GI actually sat with her during my follow-up and scheduled her colonoscopy for her. That's how I got my mom to do a colonoscopy. Sometimes you have to be just a little strategic, but you can get it done. And if you have a great doctor, they'll work with you to help them to navigate whatever barriers. My mom was like, well, I don't know about insurance and I have to take off of work and all of this stuff. But we got through it together. And that's how I got my mom. And you know what? She had a huge polyp and it literally saved her life. So fight for your loved ones as much as you would fight for yourselves, especially those who there's so much ignorance and so much stigma and so much fear and shame in all of this. I didn't share my story for 2 years after I was diagnosed. Nobody knew except for my closest people. And even those didn't know that I had an ostomy. And so that's why now I speak out, because you know what? It's the stigma and the fear and the barriers that kill more than the disease.
There was another question about just additional tips for helping the process of follow-up. So when people get a positive stool blood test, what are some of the effective ways? And so obviously we've seen, doctor letters or calls to, ensure that this is make sure people understand what that means, the initial screening, suggests you need further screening to really confirm and understand what's going on. Dr. Tepe, is there other things that the community health workers, it sounds like in extreme cases, you might get a home visit and more sort of that counseling approach.
Shannon, you want to go ahead?
Yeah, you want either one.
So, for me, one thing that I've been doing is I go to the Cologuard Classic every year, which is put on by Exact Sciences. And I have made connections to say that I did research at 3 o'clock one morning. It was just bothering me. This is the kind of thing that bothers me every night. I was like, how many people who are of African descent follow up a positive Cologuard or other screening with a colonoscopy or a doctor's visit? I thought I was going to have to find those numbers myself. So I started researching this, and somebody already did a study. Only 25% of people who are of African descent who get a positive Cologuard FIT or fecal occult blood test follow up with a doctor or a colonoscopy in 2 years. That means that 75% of people who look like me are not following up and are still possibly dying from this disease when they already started the screening process, whether it's fear or other barriers. So I am trying to figure out through my connections with Exact Sciences and Cologuard to figure out how to bridge the gap between somebody getting a positive Cologuard test and possibly Cologuard and Exact Sciences having somebody who can navigate them to find a doctor and follow up and nag them to get followed up. Even if that has to be me and I do it on a volunteer basis, I will do that to get that 75% lowered, because I'd rather the numbers are flipped, right? That's the only way to save lives. What's the point of doing a screening if you don't follow up? It's not complete. The only screening that is complete is the one that started, it's done, and then it's followed up with a colonoscopy if you're positive. Otherwise, you did it for nothing.
I would echo what Shannon said. I think fear is a big one, right? Fear and mistrust. And just, yeah, I think fear is probably the biggest one. And then, yes, you go through many of the social conditions, right, that people are faced with: the transportation, the time off work, the prep, the needing the companion and person to get you there and to bring you home, navigating an unfamiliar system. Again, even if you trusted your primary care doctor, they're not the ones doing the colonoscopy, right? So going into a new medical system, besides fear of the colonoscopy itself or the fear that you have cancer, it's meeting all these people that may judge you or who know, speak ill of you, who knows what the fear might be. And again, some of it's cultural too. Again, talking about poop, talking about a procedure, like when you kind of feel well, right? Even if that screening test was positive, if you feel okay, why are you testing me for things, right? There's a cultural incongruence there between, how we take care of those things and think about screening versus how many folks have grown up.
Yeah.
I
Just
actually,
FYI, my husband also happens to be Jamaican American, which is a little odd.
so you understand the barriers that are even more, it's layers culturally. And then I'm Chinese Jamaican, so that's like 3 levels of stuff. But one thing that I had to say was, my family and my friends kind of ran when I was diagnosed. And it was a very hard time for us. There was a lot of death and illness in the family, so I can understand, But recently I've been isolated from my family because they don't understand that 12 years later, I'm still having long-term side effects pop up. I was just diagnosed with arthritis in both hips from the treatment 12 years out, right? In the past couple months, which is debilitating being 42. So they actually told me that they don't invite me to family gatherings because they're tired of hearing me talk about my crap. I don't know when and when to not talk about my crap. This is all in quotes. And that they're tired of hearing about it. And so that's why I created Blue Couch Chat. And the slogan is the safe place to talk about your shh, and you can finish the word. But that was my way of taking a negative, because I realized that so many people like me, their families and their friends have run, and they don't have a safe place to discuss things. And so I decided to create a safe place for all of us to talk and for us to be transparent and real. And my entire show is unscripted for a reason, is because I don't come up with predetermined questions. Everything is off the cuff and it's just real and transparent. And I think that's what comes across. And it's live, so you can come on and ask questions and have a discussion. And you can also reach out to me. I'm always here. I went through this alone at 29. I'm still single, not married. I have no kids. So it was really just me and my mom, and it was really hard. And so I made the decision that I would never let anyone else go through this alone if I could help it. And I'm sticking to that now.
Thank you, Shannon. Well, I feel like we just got started talking, but we have to wrap things up. And so I think if anyone didn't get their questions answered or has more that they want to continue to chat, certainly Shannon shared some opportunities, and I think you can connect with us through PCAD and others, and we will help continue this conversation. I know there is a post test that you will see on your screen. And we appreciate everyone being here and participating, and we'd love to hear from you going forward what questions and needs you have, and we will continue this work. Thank you so much to our speakers, sharing your different expertise with us, and we really appreciate it.